Welcome back, everyone. That was a very good debate, a fun debate. Thank you for listening. We would like to stay on time and introduce the next theme as well as the next speaker. So the next theme is the gastroparesis and both the endoscopic as well as the medical management of it. Our first speaker is Dr. Kuo. Dr. Kuo is a gastroenterologist with Mass General and works with the Center of Neurointestinal Health. And he's going to be talking about the medical management of gastroparesis. Over to Dr. Kuo. Welcome.
Thank you very much. So I'm going to talk a little bit about gastroparesis. Definition. Officially, it's delayed gastric emptying in the absence of a fixed mechanical obstruction of the pylorus or small intestine. Whoa. Looks like it's an autoplay or something. But I would argue that further research is suggesting that the line is blurred between functional dyspepsia and gastroparesis, and that we may be dealing with a spectrum of patients complaining of upper GI symptoms, some of which may have overt delayed gastric emptying, and some of them which may have the same symptoms, but not significantly delayed gastric emptying. So what are these sort of symptoms? Early satiety, bloating, fullness, heartburn, nausea, abdominal pain, weight loss, and vomiting. But what I think is really important when you take the history is the timing of the symptoms, because that gives me a lot of insight into the pathophysiology. If you get your symptoms within the first few bites, that's a bit different than somebody who gets their symptoms an hour after eating or several hours after eating, because immediate symptoms while they're eating or at the first few bites suggest more of a sensitivity accommodation issue compared to somebody who might get their symptoms a lot later. So this slide talks about some of the peripheral gastric issues. There can be motor or sensory issues with phonic hypomotility, pacemaker arrhythmias, antral hypomotility, issues with pylorus, and maybe abnormal feedbacks that occur. But it involves both the motor and the sensory aspects of the vagus nerve. Now, I threw this slide in here because there are also a whole bunch of other factors, including connections in the vagus, eventually to the brain, and afferent sensations, so that when we think about gastroparesis, it's not just purely a motor abnormality, but also a sensory thing, because all these issues have to be interpreted locally as well as eventually through the brain. So I like to think of these issues as a neuropathy with motor issues that can have dysmotility, either too fast or too slow, issues with accommodation or abnormal reflexes, but also issues with sensory, pain or discomfort, nausea, abnormal reflexes, which leads to the opportunity for desensitization and neuromodulation. So to measure gastric emptying, a few points I want to make. Scintigraphy exists. It can detect rapid emptying, which is important because the symptoms for rapid and delayed emptying are almost the same. Small amount of radiation exposure. If you get these studies, you want them to be 4 hours. If I get a 2-hour study, I want it repeated at 4 hours because 2-hour studies give you T1/2s that are extrapolated and frequently overcall gastroparesis. The results are usually reported as a percent of meal retained, and normal is less than 10% at 4 hours. But I want to emphasize here, there are no standards for patients who have had gastrectomy, gastric bypass, or operations luminally and disrupted stomach. So if you have those patients, don't bother ordering a scintigraphy because we won't be able to interpret what those results are at all. So some issues, there are poor correlations between symptoms and gastric emptying times, large variability within individual patients. Results are influenced by gender, serum glucose, weight, and menstrual cycles. So hyperglycemia will cause delay in gastric emptying. Short studies at 90 minutes are extrapolated and frequently overcall gastroparesis. And there's poor standardization between sites and response. Results of delayed gastric emptying severity don't often predict response to therapy. There are other techniques, the wireless motility capsule that measures pH and pressure. And here you can measure gut transit motility as an ambulatory test where it empties an indigestible object, and normal emptying time to the stomach is 5 hours with a good correlation with scintigraphy. This gives you a sense of the advantage of the wireless motility capsule, if you can get it, is that you get stomach emptying, small bowel transit, and colonic transit all at the same time. And that can be relevant because a lot of patients with potential gastroparesis don't have dysmotility only defined in the stomach. It can also occur throughout the entire GI tract. And you want to be aware of that potentially if you have somebody with diffuse GI dysmotility. So this is just marking through different other tests. Radiopaque markers have been used in the past to measure gastric emptying, but I want to bring up the C13 actinoic test because this you will hear about. It's FDA approved, has a CPT code. You basically eat a green sandwich with green because of spirulina labeled C13, and they give you a T1 half time. Now, as I mentioned before, T1 half is not as ideal as an actual emptying measurement. And you also need to have normal intestinal absorption, liver metabolism, and lung function, because all these have to be in place to model out how the emptying will occur with a breath test. There have been some issues with spirulina substrate consistency, but this test is available clinically, but you have to send the samples to one lab nationally, and it's often used for research, mainly as because of ambulatory ease of use for gastric emptying delay qualifications. There's also MRI that's being developed, and we've done some work here measuring emptying accommodation, peristalsis, and dyskinesis. So a lot of the things that you think about heart abnormalities, you can measure with an MRI, but this is still resource consuming and not for prime time yet. So treatment of gastroparesis, I think a lot of the issues include correcting the underlying condition, review the medications, control the hyperglycemia. Hyperglycemia causes delayed gastric emptying. Hypoglycemia causes rapid gastric emptying. You want to correct the hydration and nutrition and dietary changes, small frequent meals, less residue, low fat. And then we'll talk more about medical treatment and behavioral modification. So one key thing here is for failures, big compression of G tubes and J tubes is not something we recommend at all, because these patients may get some temporary relief for decompression, but they end up becoming gastric cripples. And so that we strongly do not recommend gastric decompression. But we do consider for enteral feeding, if you want to bypass the stomach, a trial of NJ tube feedings, which is usually done in the inpatient setting, and then begun to see if they can actually tolerate the tube feeds themselves. And we don't recommend surgery for gastroparesis with regards to gastrectomies or anything of the like. So prokinetic therapies, there's a couple out there, metoclopramide, erythromycin. I put domperidone and cisapride in quotes because they're not actually conveniently available within the US. But just a few words on metoclopramide. The one benefit of this drug is it's available in multiple different forms, IV, PO, sublingual, and now even intranasal. And it has the benefit of prokinetic as well as antiemetic. And so you can kill two birds with one stone. But again, the major issue here is that a lot of patients have CNS side effects, as I described up there, including Parkinson's, akathisias, and neuroleptic malignant syndrome, and issues with tardive dyskinesia. So it's a great medication to potentially use in a pinch in the ER when they can't take PO, but you have to be careful of chronic use. And the risk factors include age greater than 70 years and length of use in higher doses. Domperidone, you may hear about it. It's available in PO and not IV. In the rest of the world, it's used commonly and it has a prokinetic antiemetic effect. There are a couple studies looking at its benefit, and it improves symptoms in some gastric emptying delay. The main issue is that there are some concerns about the cardiac outcomes, which is why it's not FDA approved in the US. And so you need an IND actually to prescribe it in the US, which is a bit of a regulatory issue. Clinical trials, though, are underway for newer forms of the altered versions of domperidone to decrease the safety risk profile. So be aware there are clinical trials for gastroparesis for this versions of this drug. A word about erythromycin, you know, it's an antibiotic. It mimics the action of Modulin and increases phase 3 migrating motor complexes. So the key dose here is not the antibiotic doses of 250 to 500, but actually 1 to 2 milligrams. So it's 50 to 100. And also, it is FDA approved for diabetic gastroparesis. You have to be aware of tachyphylaxis. That means if you leave these patients on this drug, there will be loss of effect. So we recommend drug holidays, 2 weeks on, 1 week off, or some variation of that amount. This is helpful for moving GI motility, but not necessarily helpful for affecting gastric sensation. So antiemetic therapies is a big class. There's many different antiemetics, from phenothiazines to antihistamines to anticholinergics. And I mentioned metoclopramide. 5-HT3 antagonists are powerful antiemetics. And there's also some other unique classes like Marinol, benzodiazepines, prednisone, and Haldol, and even neurokinin antagonists, where they're actually going gastroparesis trials as we speak. So the key thing about these medications are that they tack an important aspect of gastroparesis complaints, and that is the nausea and vomiting. It may not necessarily improve emptying. In fact, many of these actually inhibit emptying to some slight degree. But if nausea and vomiting is a major component of gastroparesis, this is a great choice for target. Now, Botox. There are over 15 trials to date, but only 2 are randomized placebo-controlled trials. And I mentioned them here. They're small, but they show that there are no change in symptoms or GSI scores when you do randomized placebo sham-controlled studies. And so I find this important to understand that if you just gave Botox randomly, you told you gave the patient they gave Botox, they would get better. But if you really subjected it to sham-controlled studies, there is no benefit. Now, one could argue we don't know which patients might benefit, but what I feel here is that since the sham-controlled trials show no benefit, I personally do not give any Botox. So people talk about gastric electrical stimulation. The idea here is that you entrain the slow waves with low frequency, long dose purations. But this technique has a lot of effort to try to place it in patients, does not increase gastric emptying. There are over 30 studies published to date, 6 are blinded, and they're various study sizes, but it does show maybe some improvement in nausea and vomiting, some improvement in glycemic control, not helpful at all for pain and bloating, less helpful for those on chronic narcotics, and does not improve gastric emptying. And no change, ironically, in electrical rhythm, and maybe better in diabetics and non-diabetics. We don't offer it because the data is not overwhelming in terms of being controlled, but the theory is exciting in terms of changing the electrical rhythms or possibly even something else in the GI tract. And so that leads to there are other devices that are currently being evaluated, such as vagal nerve stimulation non-invasively, where it stimulates an auricular branch of the vagus nerve, and even some approach with magnetic stimulation to the back of the spinal afferents. So the point is, these are in early development, and there are ongoing active clinical trials for gastroparesis in this area. I know pyloromyotomy is going to be talked about in detail, but I want to make this point. I want to throw this bomb in here right now. There are no uncontrolled trials, no sham trials to date for this technology. So there is a need for controlled studies that need well-characterized gastroparesis, measurements of anteroduodenal motor function and pylorus, which can be done by antiflip or other sorts of anteroduodenal motility measurements, to try to find out what are the proper predictors for successful outcomes. But right now, there are some intriguing results from these sort of surgical studies, but they are not sham controlled. And so I think there could be a heavy effect of patients undergoing the fact that know they had an operation and hopeful that going through all the troubles of that operation are going to improve their overall perceived outcomes. So there are other future drugs under development, serotonergic drugs, prucalopride is an example, domperidone-like compounds, antiemetic-like compounds, such as NK1 agents. And these are all undergoing active trials. There's also NIH buspirone and actually additional trials. So what I'm trying to say here is there are a lot of clinical trials going on in gastroparesis pharmacologically and in other arenas, which could benefit from referral. Behavioral therapy and psychopharm. So why? A lot of patients have pain. They develop fear of eating, or associated restrictive feeding intake disorder can develop. There are psychosocial factors which can exacerbate symptoms, and there can be issues of control and manipulation behavior. So these could be amenable to cognitive behavioral therapy to try to develop better coping strategies to their symptoms and stress relaxation techniques. So there's actually an ongoing trial for CBT in gastroparesis. There's also the opportunity to do antidepressants or neuromodulation pharmacologically. And you want to avoid anticholinergic activity with some TCAs and maybe use ones with less anticholinergic activity, such as dicipramine and trazodone. And also possibly use of SSRIs, and also maybe other neuromodulators, such as gabapentin, duloxetine, and mirtazapine, where there's some small data on. There's also non-pharmacological treatments, acupuncture, use of marijuana, whether it be the THC or CBD component for pain, nausea, and appetite. So in summary, there are numerous clinical trials for gastroparesis, both in the device area as well as the pharmacological area. And also, there is now an NIH-approved trial that will be ongoing for surgery sham control. But we recommend that there's an opportunity for neuromodulation of symptoms versus just pure promotility, whether that's pharmacologically derived, brain-gut derived, whether that's with CBT or electrical stimulation, which is being further evaluated. And surgical options exist, but need to have sham controlled trials to provide convincing evidence. Thank you very much.